Okay, so we'll continue diabetes. And if we get through it fast enough, then we can do a review before the exam as well, okay? So we talked about how we classify diabetes based on the lab values, either before pregnancy or at the beginning of the pregnancy when they do their first blood tests, or if they're at high risk for all this. Well, basically all moms prenatally will get screened for GDM through a oral glucose tolerance test that's done at sometime between 24 to 28 weeks, either with a first step or a second step. And then, as we talked about yesterday, if they have these risks, then it makes their pancreas already a little weaker, if you will. You know, it will already have a dysfunction. Plus the increase in the insulin resistance that happens during pregnancy because of the HPL, the prolactin, the progesterone, and the estrogen. They all create a sustained postprandial hyperglycemia. And that's the problem when it becomes sustained, because the insulin is not bringing down the sugar. So first, let's talk about the mom and what that means for the mom. So whenever there's high sugar in the blood, just like in a non-pregnant person, that increases the serum osmolality, right? It makes the blood thicker. So then when the blood is thicker, then your body would want homeostasis. So then one of the things that happens is that your hypothalamus, let me see where that's at on here. I don't have it on here. Well, here where it says polydipsia. So whenever you have a high osmolality, your hypothalamus tells you, hey, your blood is thick. You need to dilute that. So then it increases your thirst, right? That comes from the hypothalamus. And that's where that polydipsia comes from in hyperglycemia, like in general, right? In hyperglycemia, there's 3 P's that we look for. And that tells us that the sugar is really high on a person. Polydipsia, what else are the other 2? Polyuria and polyphagia, right? So polydipsia is because of that high osmolality. And then in pregnancy, because there's a high cardiac output, so now you have more blood that's flowing. So even more so that the mom is going to have a further increase in urine. So this is a more polyuria than a non-pregnant person, because apart from her blood thickening, her increased thirst, she also has already a high cardiac output due to estrogen, right? And because the sugar is high, and she's trying to pee it out, when you check the pee, there's also going to be glucose in there. So it's going to be, her UA is going to be positive for glucose. And because she's pregnant, and anyone, again, females particularly, who have high glucose and they're peeing out a lot of glucose because their kidney's spilling it out, they're very prone to yeast infection and UTI, okay? Because that extra sugar in the perineal area attracts bacteria and yeast. So they'll have vaginal monolysis or candidiasis, and then UTI. So where does the polyphagia come from? If their sugar is in the blood, then it's not in their cells, right? Because the insulin's not taking it into their cells. So then same thing sort of with the blood being thick. The hypothalamus will tell the brain, hey, you need to eat more because you don't have any energy in your cells, right? Because the sugar is all in the blood, not in the cells. So then that triggers an increase in eating, which technically polyphagia means excessive swallowing, right? But when we say swallowing, they're actually eating a lot, okay? So it's like they have this craving all the time. And because there's no glucose in the cell, so the mom gets fatigued. So what does she use for energy also? Because it's not, there's no glucose in her cells. So then she goes into ketolysis. So in very high blood glucose, again, this is true for all diabetics. Outside of pregnancy, it's very high risk on type 1 diabetes. Also in newly diagnosed type 2 diabetes, that when they don't have glucose in their cells, they burn their fat. And so then now you're going to have ketonuria again, right? Because we associate ketonuria with ketolysis, which happens when the patient burns fat instead of carbs for energy. The danger is if this gets too high, the ketones in the blood, then the mom could go into ketoacidosis. All right. So technically that's like DKA, right? You guys learned DKA in first semester. So same thing. And then I've mentioned to you guys too that this is correlated with high blood pressure. So as there's a lot of volume due to the increase in her blood and then the serum osmolality being thick, her blood pressure increases, so which is what makes her prone to gestational hypertension that leads to preeclampsia. And that's how preeclampsia and diabetes are comorbid in pregnancy. And so when the blood pressure increases, similar to what we talked about yesterday with hypertension, there's decreased perfusion to the placenta. And so the placenta ages. And so what effect does that have on the fetus potentially? So if there's decreased fetal nutrition, there will be IOGR that leads to SGA. So this preeclamptic mom may have an SGA baby. And then worse is if the placenta ages because it's not getting enough blood, then the baby doesn't get enough oxygenated blood, goes into fetal hypoxia, and could die. Now, the other thing that happens, if hopefully this doesn't happen, is that the baby's own bone marrow is going to, and liver, will compensate for the lack of oxygen. So in the fetus, it's not only the bone marrow that produces RBC, the liver also produces RBC. And so they'll go into reactive polycythemia, and so their red blood cells will increase. So their hematocrit will be greater than 65%. And I want you to kind of just think about that as we move on to newborn in week 4, because when we talk about jaundice and all that, this plays a role in that. Okay, so that's a part of what happens to the baby. So let's look back at some other things that could happen. Let me go back to first trimester. So remember how we said here, if either this mom already comes into the pregnancy with diabetes or she is pre-GDM at the beginning of pregnancy, then in the first trimester, if there's any effect on the baby, especially in the first 8 weeks, right? This is the first 8 weeks, the baby is still in the embryo, and that's where all the organs are forming. So then the baby could get congenital anomalies. There could be heart problems, genitourinary, so kidney issues, neural tube defects, and skeletal deformities that could happen. We'll come back to these because I want you guys to understand this again moving forward into week 4, but I'll come back to that later on. So the other thing is, because now there's a lot of sugar in the blood of the mom, then that gets rerouted to the placenta to the baby's blood, right? And so that increases the glucose in the baby's blood. So the baby gets fetal hyperglycemia. And just like an adult's system, if there's high sugar in the blood, then the baby's pancreas will also react and will increase the insulin, right? Because it's a supply and demand. So the baby gets fetal hyperglycemia, which creates fetal hyperinsulinemia. And now the blood is so thick because of the increased insulin and the increased sugar in there, which could lead to fetal asphyxia, similar to fetal hypoxia. The other thing that happens is when the insulin is too high in the blood, it decreases the phospholipids in the baby's blood. And phospholipids is very important in the development of surfactant. You guys remember what surfactant is? What is surfactant? So it keeps the elasticity of the alveoli, right? So if this baby who had high glucose had high insulin because of the high glucose, will now have decreased phospholipids, will now have decreased surfactant. So if the baby is born premature, what happens? The baby is prone to RDS, respiratory distress syndrome. Okay, and we'll talk more about that, how what the other factors are that affect that. And then also again, because the sugar is very high, so then there's going to be kind of like an adult who overeats carbs, right? When you have enough sugar already, that gets stored that you use for energy, you use for your brain, then it gets stored in the liver, and then the next thing that happens to the extra carb is it becomes fatty tissues, right? Same with the baby. So then that extra sugar becomes increased fetal adipose tissue, which is what causes macrosomia or LGA, large for gestational age in babies. And when we say LGA, we're talking about how many grams? 4,000 grams or above. Okay, so these are your 9-pounders. So, and then what happens when that happens is that because the baby's too big, then the uterus of the mom is bigger, right? Because the baby is bigger. And that has its own risk. I'll talk about that in a minute. Let me go back here first again. So another thing similar to, again, an adult is because the sugar is so high in the baby's blood, then the baby's kidneys is also going to become hyperactive and will try to pee out that sugar, right? So then the baby gets fetal glucosuria as well, right? So the baby's peeing out sugar and the baby is peeing out a lot more. So when the baby's peeing out a lot more, where's the pee gonna go? In the amniotic fluid, right? Because this baby is just in this bubble, right? So then that can lead to polyhydramnios or just hydramnios, right? What does that mean? Excessive amniotic fluid. So now you got excessive fluid plus a large uterus because the baby's large. So then the brain of the mom thinks, oh wait, are we ready to go? Are we ready to deliver? Because it seems like your uterus is big enough, right? So then it increases the risk of preterm labor. So that's why your GDM and your preeclamptic moms are at risk for preterm labor. And then again, because there's preterm labor and the baby's lungs are not mature because of the decreased surfactant, then the premature baby can get RDS. So another issue, which so I've talked to some of you about whenever there's polyhydramnios is cord prolapse. We'll come back to that another time. So yeah, preterm labor will lead to preterm birth, could lead to preterm birth, and could lead to RDS in this baby. And then postpartum, because the uterus was so big, then it gets stretched out. So then when it gets stretched out, there's a risk after the baby is delivered that the mom's uterus will remain stretched and will not contract. That's called uterine atony, right? So uterine atony is the lack of tone, right? So then when the uterus doesn't have any tone, it's not contracting, it's going to keep bleeding. So mom will be at risk for postpartum hemorrhage. So how does that translate? If you were working in postpartum and your mom had GDM or preeclampsia during pregnancy, you know that you're going to watch out for uterine atony. You're going to monitor that a lot more because they're at higher risk for postpartum hemorrhage because of that. Now, when during delivery, because this baby is very big, and if the baby is going to get delivered vaginally, there's a risk of shoulder dystocia. What is shoulder dystocia? Anybody know? The occiput presents. So if the head is presenting, if the baby's vertex, the shoulder will get stuck on the mom's symphysis pubis, right? So these are some signs of shoulder dystocia for like word association purposes and test-taking purposes. So the baby's head will come out, right? Because there's cardinal movements of labor, right? So baby's head comes out, but then by the time that the shoulder is on the symphysis pubis, it gets stuck. So what is the baby gonna do? It's gonna try and back up and then try and come out again. So that's called the turtle sign. Okay, so you see like this head go out and then come back. It's not supposed to go back in, right? The baby's supposed to keep coming out. And prolonged stage 2 labor. How long is that? More than 2 hours, right? And again, in reality, it's like an hour and a half. We're kind of getting concerned, right? So that shoulder dystocia, we'll talk more about that when we talk about the peds, the newborn, I mean. So let's see what else we've missed here as far as cataphysics. Okay, so we could move into interventions. So I think I mentioned to you guys just overall, this mom would have to have a moderate intensity exercise. The contraindication is if they have preterm contractions, premature contractions, right? So they should not be doing moderate intensity exercises. So 150 minutes a week. This should be all moms, okay? Especially GDM and hypertension moms. So this could be, again, 30 minutes, 5 days a week, 15 or 15 and 15 every day, you know, however they can divide that up. But what do we consider moderate intensity exercise? So walking, unfortunately, contrary to popular belief, is not moderate intensity. It's very mild. Speed walking, swimming. How would you know? What would you tell the mom to say, okay, now if this is happening, then yes, that's moderate intensity. Your heart rate goes up. What else? You're sweating, right? You're kind of short of breath a little bit. You're huffing and puffing. Okay. Yeah. So that's moderate intensity. Okay. If you're leisurely walking at the park, that is not moderate intensity exercise.
I mean, I'm crossing the street right here, so.
Speed walk.
Okay.
Yeah, swimming. I heard somebody say swimming. Swimming's good. Low impact as well. Okay, so and then this is just FYI. I don't think you're gonna get tested on this, but you know, it's just still kind of good to know. Nice to know, not a must know. Okay, so these are the recommended weight gain based on the patient's BMI. But basically what you'll see a pattern here is that the heavier they are, the less weight they should gain a week, right? So from 1/2 pound a week to 1 pound a week. And we're talking about second, third trimester. And third trimester is the time that we really don't want them to gain a lot more weight. Because though, again, when they overeat during that time, it could go to the baby and the baby becomes larger. And then you'll have all of these dangers of dystocia. For the baby, if we're concerned about congenital anomalies, so there's tests that will be done to the mom and the baby. So this nucleotranslucency test, this is through an ultrasound. So this is a diagnostic test that's done 10 to 14 weeks of gestation. And this is really even outside of GDM. This is to screen for spina bifida. Okay, nucleotranslucency. So basically what we're saying is if we're seeing that it's clear, nucle in the neck, right? If we're seeing that it's clear in this area here, that means that it's probably not developing as fast as it should. So there's a high chance that this baby could get a neural tube defect or spina bifida. In the mom, we can do 2 tests. And they're usually at 16 to 18 weeks. So these are blood tests for the mom. They can either just have the maternal alpha-fetoprotein, or they can get a quad screen, which means 4 things that they're screening for. Okay, so the AFP is already part of the quad screen. And what these are screening for in general is Down syndrome and again, the neural tube defects. Okay, so we're screening for any spina bifida or Down syndrome, which obviously is increase in AMA, moms, but that's basically what that would tell us. Okay. We know that this mom is going to go into NST, right? Non-stress test, because we need to monitor the baby, especially in third trimester. So they're going to come in maybe 2-3 times a week for that, the L&D. And then kind of along the lines of fetal monitoring, let me start here. So this is, I kind of briefly mentioned this last week. This is part of the fetal monitoring. So one, again, we do an NST, right? Non-stress test. And what we want, what is a reassuring or reactive pattern is that the baby's heart rate will increase by at least 15 beats from baseline with fetal activity for at least 15 seconds. So that's your 15 by 15, right? So that's a reactive pattern. If you've seen this in the L&D, they will get set up with the monitor, the fetal heart monitor, right? No TOCO because mom's not in labor, so just the fetal heart monitor. They'll have like this little call light looking button, and they'll be instructed every time you feel the baby move, you press the button as they're monitoring the baby's heart rate. So they'll have like little tick marks by where the movements are, and then they can correlate that with the baby's heart rate. Okay, the baby moved here, so did the baby's heart rate increase, and how long did it increase? If it didn't increase or if it decreased, that's a bad thing, right? That's a non-reactive or non-reassuring pattern. So that's why we want a 15 by 15. Okay, so that's one. Two, if they want to investigate further, they will do a biophysical profile. So a biophysical profile will have the NST still plus an ultrasound, okay, that is looking at these 5 criteria here. So for the FHR, that's the monitoring. So it's either reactive or non-reactive, right? I just told you what reactive would be. What would you see again if it's reactive? 15 by 50 increase, right? So make sure it's an acceleration with movement, okay? By 15 beats for 15 seconds. Or 0 for non-reactive. And then these 4 will be through the ultrasound. So fetal breathing, movement. Does the baby breathe inside the womb? So what is this talking about, fetal breathing movement? So you could see like it appears like the baby is breathing, but it's like this rhythmic movement of the baby, right? That happens because of the blood flow through the baby. So we have to see that rhythmic movement of the baby's entire body. So there should be at least one episode that is greater than 30 seconds in 30 minutes. And then we also look at the body movement. So we want a extension and then return to flexion. So they're looking in the ultrasound, they're seeing the arms or the legs and see if they actually extend and then flex back. Okay, so they want at least 3 of those. And then we'll look at, in relation to that, we'll look at the tone. So this is looking at movement, this is looking at tone, but we're really watching the same thing, right? We're watching the arms extend and flex, but we're looking at 2 different qualities of that extension and flexion. How brisk is it? Okay, so here's a slow extension and flexion or lack of flexion. So, you know, baby's kind of floating around like that, not doing this, not briskly returning to flex. And then this is the volume. Sometimes you'll see this in the report as an AFI, amniotic fluid index. And the index basically kind of totals the pockets of amniotic fluid in the ultrasound, and then translate it into an index. But if we're looking at just the volume, we're looking at least 2 centimeters. So imagine you have, this is the ultrasound, right? And then let's say this is the baby. This is going to be a weird looking baby. That's the baby right there. And then here you have this pocket of fluid. So they're going to measure this. Okay, this has to be greater than 2 centimeters. And if it is, that means that this baby does not have oligohydramnios, right? What is oligohydramnios? Not enough amniotic fluid. So what's the significance of that? If there's oligohydramnios, remember this could be an LGA baby. So if there's oligohydramnios, what is the baby at risk for? Cord compression, right? The other half of you will talk about that tomorrow. Okay, but so that increases the risk of the cord compression, which could lead to fetal demise. The baby could die, right, from not getting enough perfusion. And then we also have these 2 tests that is done through an amniocentesis. And this is to, excuse me, to check and see if there's a risk that this baby is going to get delivered early, right? So the mom gets contractions early, right? So now we're going to see, okay, is this actually going to result in this baby getting delivered? So they're going to do an amniocentesis in the 3rd trimester, and they're going to check for these 2 tests, PG and the LS ratio. You're going to see this again in your ATI content mastery and in the finals. Okay, so PG and LS ratio. So PG is a enzyme that we see in the womb. So a protein, sorry. So if we have PG, if this is positive, that means that the baby's lungs are mature. So then even if the baby is delivered early, there's a lesser risk that the baby will have RDS, okay, because their lungs already mature. If PG is negative, that means that the baby's lung is not mature yet. And so that will increase the risk of RDS. In the LS ratio, so these are 2 proteins that continue to develop. And however, one of them, the lecithin, should continue to increase, while the sphingomyelin should not increase anymore. Okay, so we want a ratio greater than 2:1 or 2:1. Okay, so if the LS ratio is less than 2:1, that means that the baby's lungs are not mature, they're increased risk for RDS. If the LS ratio is greater than 2:1, then the baby is going to be likely okay, without risk of RDS during delivery. Okay, so what's bad? Negative PG, and what about the LS ratio? Less than 2:1. Okay, so low LS ratio and no PG. Okay, that means that the baby is at risk for RDS.